when someone's diagnosed, what are the key things you tell them? And also, what don't you tell them about Parkinson's?
hmm Yeah. Well, and in one of your emails setting this up, Connie, you said something like it would have been nice to have a gradual rollout of information. And I think that our healthcare system, and that includes me, we struggle with that. There's the approach that I often do utilize, which is to give people the Every Victory Counts manual from the Davis Phinney Foundation. And that's a little bit dangerous, I suppose, because it's all in there. Uh, but I think that's the lesser of two evils if the other option is, okay, well, we have this 45-minute visit. It took 40 minutes to get to this point in the conversation. And now, in the last few minutes, it's hard for us to parse out, okay, well, now you've had this shocking revelation that what you've been dealing with is Parkinson's. Maybe you suspected that. Maybe it's a total blindside. And to sort out what exactly do you need to know in this moment and how can I give that to you in this moment, there's often not time for that level of nuance, nor do people always know what they need in that initial moment. And
And,
so
and
I,
and typically, when do they see you next after you say those words?
it's often a couple months.
Okay.
So, I hand them the big book and I say, this isn't a novel, don't try, it's not homework to read this all from front to back between now and the next time that we see each other. But if you have questions, certainly reach out to me through phone or portal with those questions. But besides Google AI and all the other resources that we have, this is a vetted resource that multiple professionals from doctors and multiple other lines of care providers in healthcare and care partners have contributed to.
Right.
And so utilize it as a reference.
And do you, when just to get some specifics, when somebody does message you in the portal, and I hope most people listening have that opportunity to interact with their healthcare through an active portal, not one that lays dormant. You ask a question and nobody responds, but or that you have a phone number you can call when you have pressing, questions. Who answers? Do you answer, or do you have PAs or nurse practitioners who respond?
Yeah, this will probably vary across practices. At my practice, the messages come pretty much directly to me. They go to the inbox of my medical assistant. But then, unless it's, oh, I need to reschedule my appointment, which she would help with, they just get forwarded directly to me. And then that could either lead to me responding via portal, or occasionally, if it's something that is a little more nuanced, but not extremely complicated, it might lead to a short phone call. And sometimes it'll lead to, oh, okay, well, this is a big, important question that's going to lead to a lengthy conversation. And rather than writing paragraphs and paragraphs to each other back and forth through the portal, let's set up a sooner appointment.
And before I ask Gail and Pat what they wished they would have known or not known to begin with, I'm wondering what you've learned in that process, like the key. Um, what have you learned in terms of the diagnosis and what you tell people? I guess I don't need to steer that question. I think you know what I mean.
Oh, yes, I know what you mean. And when I started, I was trying to be helpfully vague. I said, this disease is different for different people and we'll see what happens. And what I didn't realize at the time is that it was vague enough to the point that some people left thinking, gosh, my Parkinson's could get worse and I could die in the next weeks or months. And so that's not what we're dealing with. It tends to be a long, slow disease. And so in some form or another, I'll try to incorporate a phrase like that in our initial discussion. And that's a double-edged sword too, that it is a long, slow disease. But I think for people to know, I don't expect you to wake up different tomorrow or even a year from now and have it be dramatically different than the day before. If that happens, then there's maybe something else going on that we need to explore. And so trying to convey that this is along slow disease. And that part of the reason that you have a doctor like me is to bring up what troubles you're experiencing over time to see how we can try to troubleshoot those.
Right.
That's maybe the other thing I try to convey is that, there's 25 different symptoms that can happen as part of Parkinson's. And I'm not giving you a checklist and try to rate all of these symptoms and be on the lookout for when this happens. It's more a matter of raising awareness of what can happen so that oh, that might be related to my Parkinson's and there might be something we can do about it.
Yeah. Okay. Gail and Pat, do you have something to add or some thoughts about that? What you wish you knew, didn't want to know?
We were just so busy in the research on finding what we didn't. I mean, we knew what we knew and we didn't know what we didn't know, and we were trying to find more information on what we could know and find support. We started building a team right away, which was that was a process in itself. And
What year was Sid diagnosed?
She was diagnosed in 2010. I first noticed her symptoms back, her rigidity back in 2006.
Okay.
So we're at 20 years since I said, "Why are you walking funny?" And then she had a twitchy finger,
Mm.
and so there was so much to know. And so I think I like what Aaron was saying about the slow evolvement into it was helpful because of our involvement that we got into the community and with other activities across the country. I was able to meet many other people with Parkinson's, and that was an education in itself as well because people come in various stages.
Yeah.
And, scary to, hey, what do you want to do next? That type of thing. Um, but it's a roller coaster ride, and staying on top and being ready for that next hill to go down or to go up, or, whatever
Yeah.
the turn is in that ride in our journeys. That and to learn to go with the flow with it. You know, it's a
And
process.
Gail, you talked about kind of having the opposite experience of not wanting to know too much.
Well, first my husband was diagnosed by a physical therapist after he had shoulder surgery, which I guess is very common in people with undiagnosed Parkinson's because they're so tight and rigid. It's a physical therapist who told him he has Parkinson's. So when we did go to the doctor, the one thing that he did, which was very nice, I guess, is that he said, "Congratulations, you will not die from this illness." And that was a big relief. Um, and and then my husband, being a physician, started reading up. He knew quite a bit about Parkinson's, so he was reading up more, and he kept on wanting to share it with me. But after reading the first chapter, I said, "No, thank you," because I could not find anything that gave me a feeling of hope. Um, and actually, it is a very slow process, and it is like a honeymoon. And each thing that comes along, you manage. So at the beginning, it's really you say to yourself, "Oh, this disease is not a big deal." But I for one, and that's just me. I mean, I went to have a baby, and I didn't even know what I was doing. No, I didn't know how it was, how babies are made, but I wasn't aware of when I should call my doctor. I didn't want to know. I figured I'll know when the time comes. So that's the way I felt about Parkinson's. However, now that I look back, I would have had an easier time if I was aware of all the subtleties. There are so many subtleties that we gloss over or
Mm.
we don't take really note of, and then we let it slide, and then those subtleties become bigger and bigger, and they're not so subtle. It would have been helpful, very helpful for me if I was aware of some of those subtleties along the way.
That's fair. How do you feel about that? And also, Aaron, uh, we have two very active care partners here. Well, three, counting me. And I wonder, we also hear from our listeners quite often that their person doesn't want them in the doctor's office or doesn't want other people to know, and that kind of inhibits their capacity to build a team or to understand the disease better. How do you manage that, especially with the newly diagnosed?
Yeah. I'm As you're asking the question, it makes me wonder whether I should be more proactive about counseling. It's important to engage the other people in your life, the people that you already know
Mm.
and love, and then other care providers, whether it be PT, OT, speech, or, oh, you don't even have a regular doctor. Well, that would be a good thing to set up. Uh, I think that I often sometimes there are visits where I can kind of sense, like, let's say the husband has Parkinson's and the wife is the care partner, and she's trying to bring up things that he's trying to not have be brought up. And I think to some extent my role is to mediate that and say, well, and to do some level setting. Like, it's probably not helpful to look for trouble and find, oh, well, when exactly did you lose your sense of smell? Some things you can just gloss over and, focus on other things. Uh, and so I'll sometimes try to use the framework of, it's important to be aware that this, that, and the other symptom, tremor, lightheadedness, constipation, these can be Parkinson's related. And since I'm a Parkinson's doctor, I have things that I can tell you that may be helpful about those.
Right.
Uh, and so, the intake form that we have that patients fill out when they come in, one of the only important questions on there is, what is your number one concern to discuss today? And then we talk about, is that Parkinson's related or not? Are there treatments for that or not? And what are the pros and cons of those treatments? I think if they just say follow up, as happens sometimes on that form, well, then we haven't even started the conversation yet about, is there something that I can help with during our time together today?
Yeah.
And so I think having in mind, and whether you come in together or separately or with your doctor's permission, make a audio recording so that you can fact check and see, what did he really say, as we
Yeah, and as you
talk
know,
about so many things.
as you know, I really encourage people to do that because there are disagreements after the fact.
Mm-hmm.
But I'm so I think, and exactly, you have to ask the doctor's permission, let them know you'd like to record it for your own and for your own use, and some of these recordings, like on the Otter AI, will give you will give you the transcript, which is quite helpful. But I'm also wondering, so if the care partner is bringing up topics that the person with Parkinson's is trying to avoid discussing, are you able to lock into that, or do you? I'm not asking who you favor more, one over the other, but I am saying that, the care partner, their views and observations, our views and observations hold weight. So how do you parse that in the office?
Yeah, well, it's really the art of medicine. And so let's take kind of a less touchy subject, maybe like, oh, remember you say that you're lightheaded like all the time. And so they're saying that to me and to the person with Parkinson's. And I'll say, okay, well, orthostatic hypotension, having your blood pressure drop when you stand up, that can be a really common symptom for people with Parkinson's. Is that troublesome for you? And try to make it kind of a three-way dialogue as opposed to any one set of people pairing off and not engaging the other one. And
Yeah.
if they say, oh, well, yeah, that happens, but it's not that big of a deal, then we may just let it lie until maybe if it ever becomes a bigger deal in the future. And I'll say, okay, well, that's not what's troubling you. Are there other symptoms that you would like to focus on? And
Yeah.
I mentioned, starting with a less touchy one like orthostatic hypotension, if it's apathy or depression or anxiety, then those are often more challenging. And if the care partner says, you're so depressed, or something like this, then I'll try to engage in that conversation with trying to distinguish, what are normal human emotions? The grief of a new diagnosis, the grief of advancing to a new stage, the sadness of living with a disease that can be difficult at times. And how do grief and sadness differ from depression, where more often than not, you're blue down or depressed and you don't enjoy things that you used to enjoy, even when you're able to do them and are in the midst of doing them? And talking about, well, is this something that we just are going to need some time to process? Is a talk therapist appropriate? Is a medication appropriate? And trying to suss out those, how big of an issue is this? Is it a clinical depression? Is it a normal human emotion? And how do we proceed?
Yeah, thank you. I think that the depression piece is especially hard because it's hard to admit it. It's hard to identify it. I know early on, even with my husband, that when he was diagnosed, he said, "I'm not depressed," and then he told the doctor he felt like he was, being held underwater. I said,
No, I'm not depressed, but I do feel like I'm drowning.
yeah, yeah. Which, I'm sitting in the care partner chair and I'm like, excuse me,
Mm-hmm.
and it's, it's obvious you're going to go through a full range of emotion as a care partner and the person with Parkinson's throughout this disease. And it's not an urgent disease that requires, immediate attention in the way that certain cancer diagnoses or other diseases do, right? Like requiring surgery or, immediate intervention. And so there's also sort of this like, well, let's step back a second. And I think that's hard too for the care partner who might prefer action on both of their parts. But I think that the early years are rough. Getting into the middle years, which I know a lot of our listeners are in that category as well, things start to get more specific, right? And even still very confusing. I think that that's one of our challenges is that there are, I liken it to looking up at the stars, and every star in the sky could be a symptom of Parkinson's, that needs some sort of treatment, and it can be overwhelming, for us. But I don't know, and we're talking today with a specialist, a movement disorder specialist. So I'm wondering what other care partners feel. And Jenna, do we have any specific questions from care partners about that we can answer now that might help? Since we have Erin with us.
Yeah, absolutely. We have a number, not surprisingly, we have a number of great questions, and they do, we spent a lot of time talking about that critical inflection point of diagnosis, but we also have questions that are coming up for people later on throughout their experience too. So I'll kind of maybe start in the early stage question and then, progress a little bit along as well. But one of the questions that we had is kind of around counseling when to start meds. And actually, Erin is a great person to ask. This is the person who's written this essay and helped us navigate how we talk about this largely as a foundation. But, for folks who are living with Parkinson's who may kind of be grappling with, I don't want to start medication my whole life. I'm not starting now. I don't want to be on a bunch of medications. How do you navigate that for folks who may be adverse? And then also, how do you address, some of the information out there that's like, you should wait, you should hold off, things like that. How do you help both care partners and people with Parkinson's navigate that decision path early on in their experience?
Mm-hmm. Yeah, lots of good questions in there. And to the question of, how do we talk about when to start meds and, I don't want to take meds. I understand not wanting to be on levodopa for the rest of your life, but I think the bigger truth that underlies that is you don't want to have Parkinson's for the rest of your life. And it sucks, but here we are. And so once we can reach some degree of acceptance around that, then it's a matter of, okay, well, the meds don't slow disease progression, but they can be quite helpful at alleviating symptoms. And so one of the key words in my discussions with patients is troublesome. And so, yeah, your right hand shakes. How troublesome is that in your daily activities or in the way that you feel that you're perceived by people? And if your symptoms are what you would call troublesome, well, this is your life, and I want you to have less trouble in your life if we can. And so if your symptoms are troublesome, I would suggest that we at least talk about medicine and probably start medicine. So that's kind of one of those
That's a good
questions
answer, I
answered.
think. Yeah, I think troublesome is a good one, and there is a lot of reticence around using meds, especially, many people that you diagnose are already on other medications,
Mhm.
and so that's fair. Um, other questions, Jenna?
Yeah, one other really is interesting, actually. We had a question about NOH, and I think we can, look specifically about this question, but maybe it translates to a broader question as well. So, as new symptoms are coming along and as a care partner, you might be helping with trying to monitor, your person. This person is struggling specifically with finding a blood pressure monitor that will work for their person when, to really detect low blood pressures. I don't know if you have any guidance from folks that you've treated or that are trying to monitor that at home of how to navigate that. But I wonder too, just generally about, how do you help care partners become a real partner to doctors over time? And what does it look like to take on that role of monitoring and reporting data? And do you have any advice for folks who are finding themselves in that space where they feel like they are responsible at home and then responsible for reporting up and all of that challenging stuff?
Mhm. Well, I think there's a sweet spot with symptom monitoring where I think it's potentially unhealthy both for the care partner and for the person with Parkinson's to have symptom tracking become like one of their major life activities. I think that that is almost always going to be overkill. And so sometimes people come in with a 3-ring binder and color coded tabs, and that's usually going to be more information than I need, which maybe makes it more information than they themselves need also. I don't need your systolic and diastolic blood pressure 5 times a day for the last 6 months. I need, oh, well, one time I stood up and was lightheaded. And even after I sat back down, my blood pressure was 80 over 50. It's like, okay, well, I kind of know what we're talking about. And if we're talking about NOH, neurogenic orthostatic hypotension, the sweet spot that I try to set for people is, okay, well, at least a few times a week, if you're having symptoms, then check your blood pressure. And we talk about lie down first and check it, and then stand up and check it and see how much it drops. Uh, so check it maybe a few times a week, and check it when you're having this symptom and collect at least one data point of, oh yeah, I was having a real dizzy morning. And when I was lying down, my top number, the systolic, was 140. But gosh, even after I'd stood up for 2 minutes, it was 90. That's orthostatic hypotension. And we'll talk about behavioral modifications like more fluids and potentially even the prescription meds that can raise the blood pressure.
And I would interpret your answer there too, Aaron, back to our friend in the chat who was asking. I think the data that you would need is the blood pressure monitor we have isn't even reading, it's so low. What can we do? Like that
Yeah,
might be enough data for
the
you to
question
help
has been
that person
answered.
out. So,
Yeah.
I think to your point that we want to be, we may feel compelled to be incredibly precise with how we report. And I think, what you're advocating is like precision can take over your life, can become burdensome, and maybe isn't exactly what a really, great partner on your care team needs from you. So just when you notice those things that are, distressing, to share them up.
Yeah, if it's
And
not
also,
reading because it's too low, like if you're standing there and trying not to faint so you can get a blood pressure, like the question has been answered. Like,
yeah,
I don't care whether it's 90 over 60 or 50 over 30, which most cuffs can't read that low.
yeah.
This is a big problem, and the numbers are not that important.
Yeah, and let's be clear that the big problem with dizziness is that your person with Parkinson's might fall and be injured, and it is a common contribution to people falling, and so this is a big problem and needs attention. And any type of dizziness, the perception of it is so important for the person with Parkinson's to report, right? And to keep themselves safe and learn some techniques around that. But great answer there. And there's so much else in the chat, Jenna. What are we missing? I know there's a bunch of people talking about falling as well.
Yeah, I think falling is always a topic, to discuss, certainly. So we can certainly talk about that, is the, we've covered falling, we've covered how to prevent it, how to address it, how to fall safely, how to pick up your person safely, all of that. So if you're looking for that kind of information, we do have some resources on that. I would say maybe, Erin, from your perspective, as people are starting to, experience symptoms that may result in falling, how are you helping people navigate, or how are you seeing people successfully navigate that as a care partner? I think that's a real source of fear. What are some things you can offer that, might help folks with that?
Well, I'll maybe start with advanced Parkinson's, people that are falling for a variety of reasons. I think there's a lot of fear about it, and there's a lot of guilt about it. And I think to whatever degree I, as someone's doctor, can unload some of that guilt and say, it's not realistic to you as the care partner to expect to be holding the elbow every time somebody stands up, and that some falls are inevitable, and you can let yourself off the hook a little bit. Like, this doesn't need to be ruining your life, worrying about every move that your person with Parkinson's makes. And so that's kind of for advanced stage. Like, sometimes there's just not much more that you can do. But much before that, let's say someone's maybe had a first fall, it's trying to sort out, well, what made you fall? Did you trip? Do we need to get rid of the throw rugs? Did you faint? And we need to talk about orthostatic hypotension. Are you starting to freeze where the feet are sticking to the floor? And med adjustments or new meds maybe could be helpful with that. Or is it you're balanced and it's time to have a conversation about, do we need to think about a cane or a walker or a specialized walker or even a wheelchair at times? So I think sorting out what's causing the fall goes a long way.
Right.
I want to also interject or ask another question on this, because one of our listeners is talking about their person who had gone downhill pretty quickly. And then subsequently in the chat, she's also said that her doctor gave them sort of a timeline. He's gone downhill rather quickly. And we've seen that happen among our friends who seem to have been doing very well with Parkinson's and then suddenly took a nosedive. But I'm wondering, it sounds like their doctor gave her sort of a timeline to expect, perhaps for how long he would live. Do you do that? Is that normal? Or can you anticipate that?
Well, the question is, that may not be a very normal thing to do, but it is something that I try to do. With the caveat of, there's a pretty big standard deviation here where I could be off on the low end or off on the high end. But I think for people to have an idea of, well, we might be, if we want to go to the Botanic Gardens this week, is a wheelchair for the first time going to be this year or is it going to be next year? I doing this a lot, I think this is one place where an experienced clinician still has a pretty good lead on AI, which is, I know the symptoms you're having. I've seen lots of other people with similar situations. My guess is pretty good. It's not perfect, but we can maybe get a sense of, okay, well, it's maybe a year until you start using a cane, maybe 3 years till you start using a walker. I think I maybe am more aggressive about giving people numbers than some doctors are. And that's not for everybody. I don't usually do it if people don't ask for it. But if they ask for it, I try to give my best guess with the caveat that all the crystal balls are broken and it's just a best guess.
Okay. Yeah. And I think for some people that could be helpful. I also think it's really important, and we've talked about this before, and I'm actually wondering, Pat, since you've had a lot of changes with Sid's situation over the last few years and a lot of treatments, how informed do you keep your adult children? And talk a little bit about that too, because I think it does get hard on the extended family, especially if they don't know what's going on.
Yeah, we keep our children are all on top of what's going on. We have them over all the time, or we're on the phone. We go visit. We have kids in 3 different states, and I think 3 states. But they are all aware and take ownership of being a care person when they're around us.
Okay.
Grandkids the same way.
Yeah.
You know, it's heartwarming to see my grandchildren, you know, cozy up to Sydney and ask her what she needs and if they can help her and things like that. And if they go for a walk with her, then she's their best. I mean, they're her best friend if they'll go for a walk with her, and so on. So it's important to keep our family an open communication. Sometimes some members of extended family don't want to really understand the whole perplexities of everything. They just want everything to be just, bubble gum and unicorns and so on. And everything's positive and great. But I said, yeah, she's doing great, but you should have seen her this morning. But no, but to answer the question, kids are on top. We keep them informed. We're going into surgery next week, and each one of them have been visited and talked about that.
Okay. I think it is hard when sometime when your adult children or your friends don't want to acknowledge your experience as a care partner, how difficult.
As a care partner, that's a whole different story. I don't know if they have my experience as a care partner, but sometimes I wish, more people asked how am I doing. But on occasion I do get that, which is really nice. My kids don't really. Well, we have a blended family. My kids pretty much ask me how I'm doing a lot, but even with her kids, and I look at them all as one, but they at times will understand that I'm doing, but I don't know that I really feel all of the love sometimes. But
Yeah, it's hard. I think it is hard. And Gail, you work with a lot of care partners now, and you know how
Yes.
stressed people get and how hard it is sometimes not to be acknowledged for that. And I wonder in the office too, Erin, if you see that, you experience that, especially when the person with Parkinson's comes in, all, perked up and trying to show their best side to you. How do you deal with that when the care partner is sitting there going, what?
Mm-hmm.
How do we manage that?
Yeah. Well, it's maybe another thing that I wish that I had more time for is the how how are you doing as the care partner? Because I think the fear as the clinician is that that's going to open a whole nother can of worms, and maybe for the next 5 or 10 minutes, we've got more things to address than we have time to address. So it's a challenge.
Yeah.
And I appreciate that. Yeah, go ahead, Gail, please.
Oh, no, I didn't mean to interrupt you. I thought the next time around. But after my husband passed away, people will come literally coming out of the woodwork and saying to me, how did you do it? How did you manage? It's such a hard job. I couldn't believe that you stood by him. I couldn't believe how much work you had. And that came out after he passed away. And then I start thinking, well, yeah, I really did. And I was always comparing my life to someone my age who had a partner that did not have Parkinson's. And it was like night and day.
Yeah.
So when they congratulated me, even though I didn't know everyone was seeing what was going on, they acknowledged that they were super impressed, and we do what we have to do. It's our job. Um, Sometimes you don't even realize how different our life would have been if we didn't have to handle this 24/7.
Yeah, we don't get to know that, Gail, but
Yeah. Well, the other thing is when I speak to a caregiver, sometimes I tell them that they themselves should write to the office with an email talking about their concerns and that maybe it could be brought up at the next visit before they come in for their annual or semi-annual visit. Send an email to go to the doctor to give all these things that are disturbing them as a care partner, to hope that these would be brought up during the visit.
Yeah. I like the suggestions in the chat. There's some wonderful suggestions from people, and also concurrence on the fact that their person shows up in the doctor's office, with their game face on, and
Taking their big steps.
Yeah. I remember they would always ask Gene to walk down the hall, and God, he was so good. My God, huge strides.
Yeah, they definitely know how to play up, but I don't think it fools the doctor. I think, especially Dr. Haug's been at this for 14 years, as he told us, and so they know, and I think when we sit down and we have the conversations in the office, it's helpful. And I think, Gail, to your point, it's very important that the person with Parkinson's allows the care partner to interact with the doctor by signing the appropriate releases, so that they can draw attention to some of these.
If you call us a care partner, that's what a partner is. And the responsibility, it is a 50-50. Sure, I didn't have the symptoms myself, but I had to manage the results of the symptoms. So why don't I have an equal say in what's going on?
Yeah. Wow, that's a really good statement.
No, thank you.
What do you think about that, Aaron?
On the topic of, these challenging, advanced care planning and care partner burden and all of that, I wonder, if Dr. Haug, you can talk a little bit about whether you in your practice, and how you integrate palliative care or, suggest palliative care, how you see people do that. I mean, you've already spoken to a number of values-based kind of care approaches that you take, but you've also talked about, the limited time that you have with folks and things like that. And so I just wonder, if palliative care is a tool that you see families using. And, just a reminder to everyone here, palliative care is not just hospice. Palliative care and the approaches can be used throughout your life with Parkinson's, and have, the practices do a lot to address a lot of the things we're talking about here, emotional burden, and can really help take care of care partners too. So I don't know if Aaron, if you've seen folks interact with that, and anyone else on the panel too, who might, speak a little bit about palliative care.
So working here in Colorado, where Dr. Benzie Kluger set up the original neuropalliative care clinic at the University of Colorado, and he's now doing something similar in Rochester, New York, and it's starting to spread a little bit throughout the country. I think that palliative just means to alleviate suffering. And so palliative care can be appropriate from the day that a person is diagnosed with Parkinson's, even if they've got 20 or 30 years to live. I think that logistically how to operationalize that can be a challenge, because some palliative care companies throughout the community really only have palliative as the doorstep to hospice, and they're not looking to provide palliative care to someone for years and years. And so that's a little bit of a grab bag, and just maybe asking your doctor or medical provider about palliative care, and could I get a referral? We're dealing with more symptoms, more care partner burden. It would be nice to have another sort of medical professional to interact with, and then see if you can establish some helpful connection there.
Yeah, and I think a lot of times the palliative care network allows you, as the care partner, more access to, spiritual support, emotional support, and allows your person with Parkinson's perhaps more direct access to those other modalities, that you mentioned earlier, speech therapy. And, it gets very frustrating for us when our person with Parkinson's struggles with speech, and it's something they need, and because that is also an indication that swallowing could be a problem. And that's, of course, a very high risk for people to choke and then also to even develop pneumonia. So I think it's, it's very important that we stay on top of these things. And if you can't find it in your practice at home and you can reach out and maybe just expand that support, it will help you as you grow and learn through the process. Jenna, other.
Jen, I just saw
Yeah, no.
something about helping to pick someone up from the ground. The person is saying they have to build that core strength. We had a class here in Boulder, Colorado, on how to help a person up from the bed or from the floor without hurting yourself. So I would suggest look for something like that, or go online and look for the proper way to lift a person, either helping them out of bed or helping them up from the floor, so that you don't end up with back surgery or spasms and things like that. And to have the patient fall because they can't. I remember times where Gene couldn't even get his legs underneath him to be able to aid me in getting up. And so I had to call a neighbor. But it's a good idea to look and see what the dynamics of a proper way to help someone up. That was one of the
Occupational
questions.
therapists and physical therapists, you can ask, come and do a shared session, and some will, give you both tools that you can practice, both to strength, but also, to your point, Gail, to just know how to do things safely and not try to just muscle through things and end up, hurt yourself, which we certainly don't want to see happen. So there's lots of great questions in the chat. One that I wanted to make sure to ask here actually kind of speaks to Gail's point of like, I'm a partner in managing these symptoms. I have to be a partner in making decisions on our care. And so there's a number of questions here kind of around, what we might think of as advanced therapies. There's not a great way to kind of categorize those, but some of those therapies that people consider sometimes later on in their Parkinson's, things like DBS, which has been around for a number of years now, but also things that are a little newer to our community, like focused ultrasound, new delivery mechanisms, ViaLive. There's lots of things. So I wonder, Erin, how are you seeing care partners participate in those kinds of decision-making processes? How are you helping folks navigate the options that are available to them and really assess, what they should do? I think that's the what should I do of it all forever as a care partner is tricky. But there's lots of options, which is sort of great and also, I think, really confusing for folks now.
Yeah. Well, it's nice that we have several advanced treatments now, DBS and the continuous infusion therapies and focused ultrasound. Generally, these come into play if a person is starting to have fluctuations. So my meds work, but they only work for 2 or 3 hours. I'm having to take them 6 times a day, or some variation on that. And so I think that it seems more prevalent, more widespread, that if we're dealing with more advanced Parkinson's, that usually the care partner is going to be at those visits. It's pretty uncommon for a person to come in and say, "Oh, I'm thinking about DBS. I didn't think to bring my spouse with me, though." So certainly, I think inviting yourself as much as you can to appointments where those discussions are planned, but sometimes those discussions come up spontaneously, and it's hard, you can't plan for that. So I think that if a person with Parkinson's in their off state really has a lot of trouble with dexterity, and you're thinking about a continuous pump therapy, then it's probably going to be the care partner that's helping to fill the syringe with medicine, load it into the pump, and apply the cannula applicator to the skin. So that's very much a team effort for someone with Parkinson's who has a severe off state. And then there's a lot of nuance to which of these medicines might be appropriate and which path to take. And the Davis Phinney Foundation has a lot of great resources through YouTube and all their other places that discuss the pros and cons of the different options.
Great. One of the other
We're getting close to the end too, as a reminder. 9 minutes left.
Yeah, but so throw more questions. We'll do our best to cover as much as we can. One of the other areas that I saw a number of people exchanging comments about is changing diagnosis. So moving from a Parkinson's diagnosis into a Parkinsonism, dealing with PSP, with MSA, with, any number of those sort of shifting diagnoses that can happen. And so, Erin, in your practice, I'm wondering how that shows up. And I think not just sort of finding the right resources or adjustments to your care, which I think is certainly part of that, but what I saw a lot of the exchange was adjustment to those things that we talked about: predictability, lifetime, life expectancy, progression, kind of loss of community, a change in, from Parkinson's of you can live well for a long time to now suddenly being hit with actually, this is going to progress really quickly and you should make plans, right? That's what I'm seeing here in the chat and just sort of the jarring nature of that. Have you supported families through that kind of experience? And, what do you offer to folks? How do you see people navigate that really challenging experience?
Yeah. Well, the challenge clinically is that Parkinsonism is the category, and most people with Parkinsonism have Parkinson disease, but there are these Parkinson's plus conditions that look the same for the first couple of years. And it's not until you get a few years in and someone's falling more than they should or fainting more than they should that it starts to raise the red flags for the clinician that this may be one of the Parkinson's plus conditions like PSP or MSA. And those diseases carry more troublesome symptoms and a shorter prognosis on average. And so there's a small silver lining to it, which is, oh, well, this has been feeling really bad to us. It makes sense that this is a worse disease. But then how to navigate that with, we thought we were going to live 20 years with Parkinson's, and maybe the prognosis with PSP is more, 7 or 8 years. That's a different timeline. And there's a whole new round of grieving that occurs along with that. And I think that having the right name for the condition, once it's possible to have the right name for it, is helpful, because then you might say, well, all these people from my support group that were diagnosed at the same time as me, my experience is nothing like theirs. Like, they still kind of look okay, and I look pretty rough. And so it can be to have a worse diagnosis is just another challenge. But I think that is a scenario where seeing at least one movement disorder specialist, and maybe more than one, because it can be hard to accurately diagnose these things, to try to be as clear as you can on, well, which path are we walking together here?
Yeah.
Would be helpful.
Gail, you experienced a version of this, firsthand.
Yes.
I don't know if you have anything you would add, to the folks that are navigating diagnoses.
I think Jean's Parkinson's, our biggest problem had nothing to do with tremors. It was all NOH. So he was diagnosed with Parkinsonism. So it's Parkinson's with an extra gift, a gift that you don't want to receive. And the more I researched into that, the more I realized that we were not going to follow the traditional Parkinson's path. And indeed, his life was shortened primarily because of that NOH. There's some things about how low the blood pressure is. It does, once you can't read it on your blood pressure cuff, it really doesn't matter. It got to the point where he was on a chair, and if he even moved forward to even think about getting up from the chair, his blood pressure would start to drop. So that was it was tough. My husband, being a physician, he knew right away. He knew right away that his symptoms, because there's something called a tilt test. And when he was on this bed and they would tilt it, I mean, his blood pressure just disappeared. You deal with it. And sure, I can't believe that some people go on for 20 something years, but we didn't. After diagnosis, maybe 12 years, But of course, his symptoms started way before that. But it was a falling. If there's a frequent falling, that's a real sign that that blood pressure just drops
Yeah.
a
And Gail,
lot.
he was ultimately, he passed away with Lewy body dementia. So that was another,
Yes, and he had an autopsy on his brain because he donated his brain for study, and he definitely had Lewy body dementia. So he had Parkinson's disease with Parkinsonism. Lewy body dementia was a thing that really sped everything up,
yeah.
everything.
So I think what's important here too, as we kind of come to the close, is that there's so many questions that were being asked, and so many of you helped each other in the chat. This is why you want to be part of a Care Partner Meetup in person if possible, and also why a person with Parkinson's benefits also from some kind of a group, a support group, because
Yes.
these are where we help each other, where we learn the most. And we can't always address everything here. We will send a follow-up, hopefully include most of these links. We've included a lot of links in the chat today, but we try to include the links in the newsletter as a follow-up and, to keep you informed and allow you to track some of these, track the answers to some of these hard questions, which aren't always easily answerable, but I think you've all done a great job of it. I think, Dr. Haug, you've helped us so much. Your demeanor is so wonderful and pleasant for a person with Parkinson's and the care partner. To hear we hear your compassion, we feel your compassion, and I think that that's the beauty of most movement disorder docs that I've met, but not all. And so I also encourage people, to look around, shop around, and find that doctor that can, really meet you where you are in this, for some of us, very long journey with Parkinson's, and for some of us, very, very scary journey. We need support and help, and it's just, Erin, thank you for being here and joining us. Do you have any closing words? We have like 2 minutes left, and I love having Gail and Pat here. It's always helpful. Jenna, you've been helpful in the chat. But Erin, if you
Yes.
want to close us out with just some thoughts or, words of encouragement.
Yeah. Well, maybe I'll take this opportunity to say what I often don't do as often as I would like to in the visit, which is to say that this is a hard job. It's hard to live with Parkinson's, and it's hard to be the care partner for someone with Parkinson's. And I would say that even being on this call already puts you ahead of where a lot of people are at. And, I, having met many people that come to the Davis Phinney Foundation events, I think that the degree to which you are showing your caring by being here can't help but also be how you are showing up for your person with Parkinson's. And so, although I don't know all of you, I would say you're doing a good job. It's a hard job, and keep doing the best you can.
Oh, thank you so much. And you know what Gail would add? What would you add, Gail?
I want to add that the Davis Phinney Foundation has a wonderful organization with ambassadors. So you can apply or notify the Phinney Foundation that you're looking for an ambassador, sometimes even in your time zone, and link up with that person. I am an ambassador, and I've had people that I speak to on a regular basis, and it's a big help. So reach out and get yourself an ambassador, someone that you can have your own personal. You can't have your own personal physician, but you can have your own personal shoulder to lean on.
Yeah, that's awesome. Thank you for that invitation. And also, Gail, you normally end with, per Erin's comment, that you're doing the best you can. Thanks for being here, everybody. We really appreciate you showing up. That's half the battle right now. So just keep showing up. Thank you so much. And thanks to you, Dr. Erin Haug, for showing up for us today. We really appreciate it.